So now that we're on here. Okay, so obviously it neutralizes, destroys, eliminates foreign materials called antigens, right? An antigen is something that the body thinks may be disease-causing or pathogenic. Generally, these are complicated molecules like proteins. White blood cells produce specific antibodies to combat foreign invasions. And do you guys remember your T cells and your memory cells and your plasma cells and all that? No? Okay, all that's involved. We'll try to distill that down a little bit. So antigens stimulate both the immune system and the inflammatory process. The inflammatory process is part of the immune system, so that really is kind of intuitive, or that really comes as no surprise to me. Okay. We have two functional areas or components of the immune system. We have humoral immunity and cell-mediated immunity. Humoral involves activating B lymphocytes, and B lymphocytes produce what are known as immunoglobulins. Okay, and basically you can look at this as an antibody that act to destroy an antigen. Cell-mediated immunity involves production of T lymphocytes. And we call those T because of the thymus gland and maturation in the thymus gland, thymosin. Lots of different antigens. There's a little table. These are some of the common ones: dust mites, animal dander mold, pollen, smoke, viruses, bacteria, cockroaches down here. A big source of antigens. And is it when they're alive or when they're dead?
Yeah.
It's a dead cockroach, yeah. Okay, immunoglobulins. I will talk about these a little bit because a couple of them are going to be very important to us in respiratory. So IgG is the most common. It's about 80% of all our immunoglobulins in plasma. These are things that often protect against childhood diseases, viral infections. IgM is about 10%, and we see this in chronic infections, such as maybe osteomyelitis, like a bone infection, or tuberculosis, something like that. IgE is associated with hypersensitivity, allergic rhinitis, asthma. They are bound to mast cells, and we'll talk about what happens when mast cells are activated and degranulate. This is something that I would expect you guys to know, that IgE is associated with hypersensitivity reactions. These are where allergies come from: allergic rhinitis, allergic asthma. IgA, mucous membranes in the respiratory tract, bronchial secretions, transfer immunity to child. IgA, I would expect you guys to know a little bit as well, just because it is associated with increased salivary and bronchial secretion. So IgE and IgA are the two ones that you run across. It is nice to know that IgG is the most common immunoglobulin. Okay, so IgE, most common, produces antibody involved in allergic asthma and rhinitis. So once exposed to an antigen, it fixes itself to the surface of a mast cell, and then once it is exposed to that antigen again, the mast cell becomes sensitized. It waits for re-exposure, and once it becomes exposed again, then of course the mast cell will degranulate, and it'll release pro-inflammatory substances. Because do we want the inflammatory process to occur if there's an infection or invasion or some kind of injury? Do we want that? What do you guys think? Yes, we do want the inflammation to occur, because inflammation brings more nutrients into the area, right? Brings more nutrients in, increases perfusion, brings cells like white blood cells into that. It's just when inflammation runs amok that it becomes problematic, and we have issues with bronchospasm, increased secretions, and even anaphylaxis at its worst. So re-exposure, the antigen-antibody reaction occurs, and a cascade of events occur, and we're only going to be able to talk about a couple of the most important cycles here. Okay, so are you guys familiar with something called an EpiPen? An EpiPen is what people that have very severe allergies, and what is that, the most severe allergic reaction called? Anaphylaxis, right? If they have an anaphylactic reaction, this can be like bee stings, exposure to peanuts, things like that. For example, my wife is severely allergic to Hymenoptera or bee stings, so she carries an EpiPen. And I'm just going to go ahead and show you guys the EpiPen, how it works. You can administer it to yourself. Sometimes you may have to help administer it. This is generally a pre-hospital thing, but it is still something good to know. So I'll go ahead and pull up that video.
And I've replaced it with a new one. So I'm going to see how much force is necessary to inject the needle into a surface. However, I'm not going to inject it into my body because that would be foolish.
So here's the EpiPen here.
So it says to pull off gray cap.
So just pull off the cap.
There's the gray cap.
And then there's a black cap. Don't put your hand anywhere near that.
Like that.
That's where the needle comes out.
You're left with this, and it says push the black tip into the outer thigh and hold it for several seconds.
Push it into the outer thigh.
Like hours if you're having an anaphylactic
It'll inject
reaction.
and you hold it for 10 seconds.
So I'm going to see how much force.
There it goes.
Not much force at all.
You can see that it's down
for several seconds, and I don't see an indication here from the needle when it's done. But definitely.
There you go. And there's a needle. It'll go right through clothing and everything. Just pops right on out. There have been lots of injuries with this because people inject themselves inadvertently. They play around with it, they inject themselves, and you should treat that like a gun, and that's the barrel of a gun. Apparently, there have been a couple of, there's a similar kind of medication that we use in the military for nerve agent overdoses. We'll talk about in a few semesters when you guys do biological hazards. It's a very similar type of syringe. It's an auto-injector, and apparently there are a couple of case reports of during the Gulf conflict back in the 90s. People were going to sleep, and they kept the syringes, the kits, in their gas mask container, and they'd use it as a pillow. And apparently there are a couple of reports of those syringes going off and injecting medication into the cranial vault with disastrous results. I personally never dealt with any of that. However, I have dealt with lots of people that inject themselves inadvertently. And can there be problems if you inadvertently inject yourself with something like epinephrine? Yeah, absolutely. Tachycardia, hypertension. Those are all side effects of epinephrine. And if in certain patients say they have a cardiac illness or hypertension, or they're taking monoamine oxidase inhibitors, that can be very problematic. So, okay, mast cell mediator. Okay, so these are released. The big one that we worry about is histamine. You also have heparin, leukotrienes, and prostaglandins, along with thromboxanes. These, of course, this, the heparin prevent clotting. Leukotrienes and prostaglandins we'll talk about in a little more detail, a couple of the pathways that occur. The chemicals immediately can lead to bronchospasm. This is a result of mast cell rupture. So again, the mast cell has been sensitized, right, by the immunoglobulin that is attached to it. The patient then gets exposed to the antigen, and those immunoglobulins recognize that antigen as potentially being a problem. They cause the mast cells to degranulate, and then all this stuff is released from the mast cell. And this is just kind of a picture of a sensitized mast cell, and degranulates, and obviously that causes a cascade of events to occur that lead to inflammation, increased secretions, and potentially bronchospasm. Okay, so here's the mast cell as it's degranulated. It basically opens up. All the what we call pro-inflammatory mediators are released and just kind of secreted out systemically in some cases. This relates to asthma, so those you guys that have chosen to do asthma in your groups, this will be a particularly important lecture. You have basically two types. You have an allergic type of asthma, and then you have non-allergic asthma. The allergic asthma is the most common type. This is the type of asthma that I have. It's generally caused by an external antigen, and we often will call these triggers. Trigger an attack. Pollen, dust, smoke, pets, cockroaches are really big down here. That's one thing if you guys get a chance to do asthma camp, in a few semesters with the kids. That's one of the things we try to teach them as well. Cockroaches are a big trigger down here. Can be treated with immunotherapy, commonly known as allergy shots. And you guys may have heard of that. Basically, an allergy shot is a steroid. It's injected, systemic, but there are some problems associated with getting systemic steroid therapy injected, or even oral systemic steroids. We'll talk about them here. So non-allergic asthma, different triggers. This can be triggered by cold air. Exercise is a big one. You heard of exercise-induced asthma. People can actually have that. Stress and infection. I know sometimes, even though I have allergic asthma, or what we call atopic is another word for allergic, sometimes when I go to the gym, I will pre-medicate with albuterol. I'll take my MDI, and I'll take a couple puffs of my MDI before I go to the gym, because I can get some bronchospasm while I'm working out, with cardio mainly. No specific antigen and no specific immune responses is involved. So this is very different than allergic asthma or allergic-related asthma, which is directly related to the immune response. Most types of asthma will be allergic, however. Okay, so we have different phases of an allergic response or an inflammatory response. We have the early phase, and this is pretty much local. So I have my local effects. So let's say that I get exposed to some pollen. What happens first? My eyes get watery, my nose gets runny, right? And then if it continues to get worse, it'll spread systemically. But I have my early phase response, local vasodilation. This causes increased vascular permeability. And what does that lead to there? Increased vascular permeability. What does that lead to? Not necessarily secretion, but you're kind of on the right. If my vessels become permeable, they become what? They leak. They become leaky, right? They leak fluid, and I have swelling of the tissue around those vessels. Obviously, I'm going to get some redness as well. Furthermore, in asthma, I can get wheezing, bronchial contraction, or bronchial spasm, cough, dyspnea, hypoxemia. That just means low levels of oxygen in the blood, as a result of mast cell degranulation and histamine release. Just know that, yes, histamine is a big thing that we worry about, but there are many other pro-inflammatory mediators that are released other than histamine. Bronchodilators can usually reverse bronchospasm. Okay, now we have what's known as the late phase response. This can develop 6 to 8 hours later. Much more difficult to resolve than early response. So someone will have the initial response that occurs after they're exposed, and let's say that they get treated. Maybe they give themselves their MDI, and they take an antihistamine, and they're doing okay, and then all of a sudden, several hours later, they develop bronchospasm again, they have lots of secretions, and they end up having to go to the hospital. And in the hospital, sometimes what we'll do is we'll say, oh, this patient's non-compliant. They caused this, they waited too long, they were pretty stupid. When in fact, what you may be dealing with is a late phase response, where they had their initial response maybe in the morning, and they did what they had to do, but now it's at that 6 to 8 hour time period, and it comes back with a vengeance, so to speak. So treatment is aimed at stopping the inflammatory progression before it occurs at this stage, because they get lots of hypersecretion, even more increased vascular permeability. Mucus plugs. And in the late phase response, so the early phase response is primarily what? What pro-inflammatory mediators released in an early phase? Histamine. Early phase response is primarily histamine release. Late phase response, we have to worry about leukotrienes and prostaglandins, and because it takes a little while for these pathways to make the right components, and we'll talk about these pathways in a little more detail. So early phase is primarily your histamine. Your late phase will involve leukotrienes and prostaglandins. Okay, late phase inflammatory response in airways, and this is actually a really important picture. This should be in your books as well. This is just a profoundly important picture, and I'll talk about it. Okay, so what happens in late phase response? So everybody's good with early phase, that I have direct release of histamines and a few other, tumor necrosis factor and other things. But histamine's what we're really worried about. And that occurs rather quickly. And then over 6 to 8 hours, what happens is the cell membrane, the phospholipid membrane of this mast cell that has degranulated, is broken down. And there's an enzyme called a phospholipase there, and that breaks some components of this phospholipid membrane of the cell, breaks them down into something called arachidonic acid. And you guys that have taken chemistry, at least if you've taken chemistry at this college, you should be familiar with arachidonic acid because it was covered when you did your organic modules. And it's very important because it is basically what the cell membrane is broken down into. Now, there are two pathways that this arachidonic acid can go through. They can go through the lipo-oxygenase pathway or the cyclooxygenase pathway. Okay? These will happen at the same time. If I go through the lipo-oxygenase pathway, I produce leukotrienes. The cyclooxygenase pathway produces prostaglandins. Both leukotrienes and prostaglandins lead to late-phase mucosal edema, mucus production, plugging, and hyperactive airways. Okay, so both of these pathways lead to all of these. And are you guys familiar with some of the newer pain medications? So we know that there are problems associated with aspirin, right? Do people take aspirin? What is aspirin? Salicylic acid, right? It is considered a non-steroidal anti-inflammatory, right? An NSAID. And where do you think it works? It works here in this pathway. Aspirin works right here. And it is known as a prostaglandin inhibitor. It blocks, and there are actually two different enzymes here. There's cyclooxygenase 1 and cyclooxygenase 2. And a newer medication, like Celebrex, are known as COX-2 inhibitors. COX is the short name for cyclooxygenase. So cyclooxygenase 2, or cyclooxygenase 1, produces a prostaglandin that helps with blood clot, or that prevents clotting and things like that. And we know that aspirin can prevent clotting, right? It can also cause erosion of the stomach, and we can have problems with the GI lining and ulcers and so on. We can get around that by giving something like Celebrex, a COX-2 inhibitor, that only inhibits COX-2 and not COX-1, so the stomach lining is preserved, and I don't have as much blood effects. So those are some of the new medications. Now, what we really have to know is that arachidonic acid goes through one of two pathways, or both, the lipo-oxygenase and the cyclooxygenase, and lipo-oxygenase produces leukotrienes, cyclooxygenase produces prostaglandins. So the medications that we give, depending on what's involved, are going to vary. Are we always going to give rescue drugs first if we need to? Yes, if the patient needs rescue, we'll give a rescue drug. Where they'll be very effective is here in the early response. This will be things like albuterol, Zopanex, things like that. Now, in the late phase response, there are other medications that we can give to either treat this or prevent this from even occurring. And these are things like leukotriene inhibitors, and there's a really popular right now, and steroids. You can give steroids as well. Okay, so corticosteroids, treatment for allergic asthma. Now, do I give a steroid as a rescue agent? Do I give steroids to rescue people? No, I always give my bronchodilator, my rescue drug first, and typically what will happen is later on, after we've rescued them or while we're rescuing them, we'll give them a steroid to prevent the late phase response. Does that make sense? So the steroid is important, but it's not a rescue agent. It can block the initial immune response and the inflammatory process. So often we will see steroids given early, but it's still, the emphasis should be on the rescue drug, the albuterol, the Zopanex. We need to get that in. Okay, So corticosteroids, where do they come from? Where do they? Okay, the adrenal gland. They're naturally produced in the adrenal gland, and there are two types, right? There are the mineral corticoids and the glucocorticoids. And the mineral corticoids basically help us regulate salt. They retain salt. That causes us to retain water. And obviously that involves aldosterone and something called the renin-angiotensin-aldosterone negative feedback mechanism that we all learned in anatomy and physiology is going to be very important here. Glucocorticoids affect carbohydrate, protein, and fat metabolism. These are also useful for anti-inflammatory activity. So if I give a glucocorticoid to somebody, what do you think will happen to their blood sugar, or often can happen to their blood sugar? It'll increase. So diabetic patients that get steroids, are they at risk for having elevated blood sugars and all the problems that go along with those? Yeah, absolutely. We give steroids to diabetics, and we do have to be more concerned about their blood sugars. Okay, it's used to treat acute and chronic asthma. We can give them via inhalation, oral, and parenteral routes. And the big inhaled corticosteroid, blue light special that I want you guys to know, and maybe you guys already know it. What is it?
Flovit.
It's one of them, but the big one that we give a lot of. Inhaled, nebulized. Something called budesonide or Pulmicort. I think Symacort's a little different. We can look at, Pulmicort or budesonide, the big steroid. Often what will happen is you'll give it with your albuterol. If somebody has that ordered, albuterol and Pulmicort. So Pulmicort is a steroid. It's very commonly given, and you'll give a lot of it down here as well. Okay. You don't really have to memorize this too much. Again, you memorize this in anatomy and physiology, the renin-angiotensin-aldosterone, and obviously pituitary gland plays a big role in that because it secretes adrenal corticotrophic hormone, or ACTH. Okay, again, there's a little table here with doses. I am not going to make you guys memorize what the glucocorticoid and the mineral corticoid strength of hydrocortisone is. Okay, I'm not going to. That's really not as relevant for us here. Okay, so the hypothalamic pituitary adrenal axis. Oh my gosh. So basically what this is the pituitary gland. And does the pituitary gland run the show, however? No, it's actually controlled by the hypothalamus. The hypothalamus runs the show, and basically the hypothalamus secretes hormones that tell the pituitary gland to secrete. So the hypothalamus runs the show. So the hypothalamus tells the pituitary to secrete something. The pituitary then secretes something that acts upon the adrenal glands, and then the adrenal glands secrete the steroids. So it's a really complicated cascade of things that occur, and I bet you're thinking, God, I'm glad I don't have to ever worry about this again when you got through it in anatomy and physiology, huh? Oops. Oops, here we go. Okay, corticosteroid mechanism of action. They block or diminish late-phase asthma response. Block or diminish late-phase asthma response by blocking the arachidonic cascade of metabolites. That's your lipooxygenase and your cyclooxygenase pathways, your leukotrienes and your prostaglandins. Those are the pathways that are blocked. They remove circulatory lymphocytes, monocytes, eosinophils, and basophils by causing them to move into lymph, bone marrow, and splenic tissue. They also inhibit macrophage and leukocyte processing of antigens and decrease the ability of the cells to respond to antigens. Are these all good things? These aren't good things, actually. So what this is telling me is that corticosteroids suppress the immune system, right? They suppress the immune response. Is that a good thing? No, it's not. So when we give steroids, we need to be aware that, yes, the steroid may help our patient, but the cost, at what cost? The cost of suppressing their immune system. So can certain people be at risk for infections and problems associated with infections. What about immunocompromised patients that get steroids? People with HIV, people with overwhelming infections. We need to be very careful, and sometimes we have to give them, but it shouldn't be something that we do arbitrarily. We do with at least considering what side effects they're going to occur here. Okay, yep, there you go, decreased production of your white cells. They do have a somewhat of a direct bronchodilation effect, or do not rather, but they do facilitate the effect of beta agonists. Can reduce airway inflammation, decrease obstruction, and ultimately improve oxygenation and ventilation, hopefully. Okay, just a little table out of your book here. Nothing really new here about as far as blocking arachidonic acid and so on. Use in airway remodeling. You guys ever heard of the word remodeling? You ever heard of that term?
Like a house?
Sort of. But it's a similar concept. So it's commonly used with people that have heart attacks, where their heart tissue remodels or changes itself after a heart attack, after it's been damaged. And sometimes that can be bad when we remodel, because we abnormally change the way things would normally function. In this case, corticosteroids can help remodel these hyperactive airways in good ways. They can prevent or suppress inflammation, which will help reshape the airways, remodel. So whoever said something about the house is very similar. We are changing the shape after repeated attacks. And we can actually have reduction of hyperresponsiveness and prevention and reduction of airway, and it should say of harmful airway remodeling here. So steroids are often a good early anti-inflammatory intervention because they can prevent the remodeling and help prevent problems in the future. However, is it the primary intervention if somebody needs rescued? No, steroids are not the primary intervention. Okay, lots of different effects. So these are short-term. Stimulate appetite, irritate stomach, headaches, mood changes, exacerbates acne. Okay, big deal there. Hypokalemia, hyperglycemia. So hypokalemia can be a big deal with my potassium if it gets too high or too low. What else causes hypokalemia? Medications, class of medications that we give a lot of. Your bronchodilators, right? Yes, your bronchodilators can cause hypokalemia. Hyperglycemia or elevated blood sugar. Okay, these are long-term. Osteoporosis, what's that? Okay, yeah, you have bone loss, can lead to fractures. Immunosuppression, which will lead to increased risk of infection. And myopathy of skeletal muscles in some cases. Okay, and then you have a little laundry list of stuff here. I'm not going to expect you to memorize all this stuff here. I want you to know the major things that are problems that are associated with steroids. What are they? Electrolyte problems, right? Electrolyte imbalances, glucose imbalance, and immunosuppression. They suppress the immune system, which can lead to all kinds of infections. Okay, oral steroids. Okay, so we can give something like prednisone orally per day. And often what they will do is they will give something called a Medrol dose pack. Have you guys ever heard of that? A Medrol dose pack. And it's given over several days. And what you do is you start off with a large dose of steroids, and then the next day you take a smaller dose and a smaller dose and a smaller dose, and you taper it down until you're off steroids. Because if you start somebody on steroids, should you ever abruptly stop the steroid? No, you should never abruptly stop the steroid, because that can cause what we call a Addison's crisis, or Addisonian crisis, which can be life-threatening. So we taper the dose of the steroid down. Can be given all kinds of different regimens are available. I just want you guys to know that we have to taper steroids down. We don't abruptly stop them. Okay, parenteral. Commonly used, common ones, hydrocortisone is the big one that you'll see given here, IM or IV. In adults, generally they'll give 125 milligrams of hydrocortisone. There's something called Solu-Cortef, and there's also something called methylprednisolone or Solumedrol. I think I was a little mistaken. I apologize. The methylprednisolone or Solumedrol is 125 milligrams. The Solu-Cortef or hydrocortisone is 100 milligrams. Solumedrol does generally have some advantages, less fluid retention due to less mineralocorticoid activity. So often what we will see given in the hospital is Solumedrol. We will give hydrocortisone or Solu-Cortef for some other issues other than inflammation. We may talk about them later on. But methylprednisolone or Solumedrol is the big one we'll see used around here. Okay, inhaled corticosteroids, we see a lot of these given. They're chemically altered to minimize systemic toxicity. This is a good thing, would you guys agree? That I'm not giving it systemically anymore, I'm giving it to where it needs to go, and that is the airways. So I don't have as many systemic problems, fewer adverse side effects, making it an ideal route. The most common side effect, and this is a blue light special, is thrush, or oral candidiasis, or candida, or yeast infection. It is a particular concern in patients that are immunocompromised, like HIV patients. So if somebody takes an inhaled corticosteroid, what do we need to do after they finish it? Rinse the mouth out. Absolutely. Rinse the mouth out. And that includes a small volume nebulizer, not only with an MDI or DPI, but if I give a small volume nebulizer, let's say I give some Pulmicort and some albuterol mixed in there, after they finish that treatment, we need to go back in there, obviously assess them, and make sure they rinse their mouth out. Okay. Nothing new there. Inhaled, low, medium, and high. Okay, fine. Most are given BID or twice daily. Produce symptom improvement in the first 1 to 2 weeks, with maximum improvement 4 to 8 weeks. So is this something that happens very quickly? No. Again, these aren't for rescuing people. Okay. All kinds of different doses here. Really the only dose that I'm going to make you guys memorize, because in clinicals you should have a drug guide, right? You should have a little drug book that you look this stuff up in. The dose that I really want you guys to memorize, and hopefully it is on here, if not, I'll go ahead and tell you that dose, is budesonide or Pulmicort. And the common dose that we run into is 0.5 milligrams. So 0.5 milligrams or 500 micrograms here. You won't see it ordered in micrograms, it'll be in milligrams. So budesonide is the big one that I want you guys to memorize for the dose, 0.5 milligrams on budesonide or Pulmicort. Okay, benefits of daily use. They are most effective for long-term control. Improve bronchial hyperresponsiveness over time, and that's what we call the positive or the good remodeling. They prevent and reverse harmful airway remodeling, fewer symptoms, inflammation, fewer severe exacerbations. So do these, for long-term control, are we talking about treating active attack? If somebody has an active asthma attack, is that what we're getting at here? No, we're getting at preventing the attack from occurring. But we can give steroids as well if they do have attack, as long as we're rescuing them. Okay, benefits. Steroid dependency, 2 forms. And this is kind of interesting. You have psychological and physiological. Psychological dependency, and this can occur with lots of different medications, not only steroids. Can this occur with even something as innocuous as ibuprofen or Motrin? Right, for pain. Yeah, I have back pain. I take ibuprofen every day, and I take it 3 times a day, and oh my gosh, I have to take it, even though it may or may not even be doing anything for me. That's a psychological dependency. Doesn't necessarily apply just to things like narcotics and benzodiazepines, where you commonly associate dependency with those. It can happen with pretty much any kind of substance. And then there's something called physiologic. And basically what happens is somebody who takes steroids for a long time, they become suppressed. And basically what happens is their body gets used to having all these steroids floating around. So does their body naturally produce steroids? They don't. The body doesn't need to. So what happens if I were to abruptly stop steroids in somebody who had physiologic dependency? They go directly into what's called Addisonian crisis or Addison's crisis. And you probably have talked about Addison's disease and anatomy and physiology and all the problems associated. And Addison's crisis can be life-threatening. The big patients that I've run into are actually migrants that try to sneak across the border. I've had many patients that have something called lupus. One of the drugs or medications you take for lupus is a steroid. So they quit taking their steroid when they cross over to try to get in the United States, and then we see them 3 or 4 days after they quit taking their steroids, and they are in an Addison's crisis, and it is life-threatening. Obviously, they're dehydrated and they have other issues going on, but it can be a life-threatening issue. Okay, withdrawal, lots of problems, low blood pressure, headaches, vomiting, nausea, a severe abdominal pain if you're talking about Addison's crisis, anorexia or lots of weight loss. Okay, so anti-asthmatics. So we talked about steroids, right? And everybody, you have at least a fairly decent idea of what's going on with a steroid and when we give it. Sometimes we give them early, and sometimes we continue giving them. While they're effective, there are other medications that we can give to prevent. So anti-asthmatics do not treat the active asthma attack. So I just want you guys to everybody's aware of that we are not given these to treat an active attack. These are not rescue medications. These are preventative medications. These are to prevent the attack from occurring, what we call maintenance medications, like the long-acting beta agonists that we talk about in the bronchodilators. That's where these fit in. These are maintenance drugs. You have different classes. You have mast cell stabilized medications, and that's the big one that we'll talk about here, the mast cell stabilizers. These include cromolyn and nedocromil. Cromolyn sodium, or Intel, is something that you'll occasionally run into, used for both allergic and non-allergic asthma, prevents rhinitis and exercise-induced bronchospasm. So here we have a medication that we can use to treat somebody that has exercise or non-allergic type of asthma. It is not a bronchodilator or an inhibitor of the action of chemical mediator release. It stabilizes the mast cell and helps prevent the mast cell from degranulating in the first place. So it's prophylactic, it's preventative. Must be used as a pre-treatment. Works to inhibit calcium influx into the mast cell. And part of the degranulation process, we're not going to go into a whole lot of detail, involves an influx of calcium, and that influx of calcium causes a bunch of changes to occur that eventually leads to destabilization and rupture. It's called a mast cell stabilizer, or sometimes you'll see an MRI, mediator release inhibitor. We don't use this term anymore because obviously MRI has other meanings. Mast cell stabilizer is the term that I'll run into. Cromolyn sodium is the big one that it's not very common, but you'll still see it used. Okay, dosage. I'm not going to make you memorize the dosage. Know what it is. Know what we use it for. It's also an alternative for children who develop side effects with theophylline. You remember what theophylline is, right? It's one of those, the backdoor bronchodilator, the phosphodiesterase inhibitor. Lots of people have lots of problems with theophylline, and that's why you don't see it given as much anymore. Cromolyn is actually considered an alternative for that in some patients. Okay, cromolyn, they're generally non-toxic. Bad taste, headache are the big side effects. So they're generally pretty safe medications. Okay, prostaglandins. They're present in almost all tissues, right? And they come from the arachidonic acid in cells, right? The cell membrane breaks down. There are two pathways, right? The lipoxygenase, cyclooxygenase. And which pathway produces prostaglandins? Lipoxygenase or cyclooxygenase? Cyclooxygenase produces prostaglandins. Lipoxygenase produces Leukotrienes. Good. Okay. Lots of different factors, edema, histamines. A bradykinin, that is just another one of the pro-inflammatory mediators released. Pulmonary embolism. Okay. And you guys have this table right out of your book here. Effects of prostaglandins in the lungs. I'm not really going to make you memorize all this stuff here in this table, so don't worry about it. Generally know that the prostaglandins, certain types of prostaglandins can cause bronchoconstriction. Okay? I'm not going to make you memorize that PGF2 is the exact prostaglandin that we're worried about. Just know that prostaglandins can lead to bronchospasm. Okay. Leukotriene modifiers. So we had prostaglandins, right? But we also have leukotrienes, the lipooxygenase pathway. That's where these medications work. And again, these medications are preventative only. Okay, they are prophylactic. They inhibit leukotriene mediator cascade that leads to inflammation. Okay. Obviously, leukotrienes are derived from arachidonic acid, and they go through the lipooxygenase pathway. Okay. Long-term control, not an acute treatment. Okay, the big agents that we have acrylate and singulair. The one that I want you guys to know is the most common, is the one that we run into a lot, is montelukast, or singulair. It's generally given in adult patients 10 milligrams every day. It's the general dose you'll see. Often you'll see it used in combination. It can be in combination with inhaled steroids and even rescue medications like albuterol or Xopenex. Again, this is actually a medication that I take, and I don't take this to rescue. I take this to prevent attacks, to prevent problems from occurring. Okay, treating upper airway congestion, allergic rhinitis. That's all allergic rhinitis means, upper airway congestion. So we've kind of gotten out of the asthma, direct asthma agents, and now we're kind of getting more into symptom relief. This is where I have sneezing, rhinorrhea, nasal congestion. Is this severe? Is this something that's serious? Allergic rhinitis? No. Can allergic rhinitis be a trigger for asthma, though? Yes, it can. So we'll talk about medications that we can use to treat allergic rhinitis. We can use intranasal medications. Often we can use things like steroids. Nasonex, for example, or what's the big one you see on the television ads now, the Nasocort, or with the little green guys that wear the green hats, and there's a little bee that flies around. Yeah, Omneris, and yeah, those are all nasal steroids. I'm not going to make you memorize all the different names of the nasal steroids. Just know that they can be given intranasally, and you can even give cromolyn intranasally as well. Cromolyn can work as an effective anti-allergy agent, but you'd have to take it for several weeks prior to allergy season beginning. It's not something that starts working very quickly. And I think what I'm going to do is I'm just going to cut it off here, and we'll just have to finish it up next week. So I'll give you guys at least 5-10 minutes to take a little break, and then I believe you guys will have Mr. Duran's class.